But yeah, I think what the story I'd like to tell is a pretty unconventional one as well. And yes, can I just check, are you guys all emerging researchers? Is that what your background is? Or are you clinicians or mixtures of the two, you know?
Mixtures.
Yeah? Yeah, okay. Well, I think it's a bit similar to me and Fiona in that sense, because you know, I always see myself as a clinician who does research, really, you know, even though, you know, I have been involved in a lot of research, but it's been very much around changing the experience of people's lives, trying to do that in the same sort of way. And, you know, I suppose if I think back, I developed this interest in psychiatry and mental health when I was a medical student, and I was a medical student in the 1970s when, you know, the world, you know, it was in the Whitlam government period when, you know, Australia was a bit behind the rest of the world, but it was really a revolutionary period, I think, at the time. And psychiatry, interestingly, was one of the areas where, probably because the human rights of patients were so poorly sort of looked after, it was seen as a sort of a revolutionary cause, and there was a thing called anti-psychiatry, which still, you know, thanks to the Scientologists, lurks around the edges, you know. But you know, it was a real thing in those days, because patients were getting such a raw deal, you know, people with serious mental illnesses, especially schizophrenia and so on. They were looked after in 19th century sort of institutions, and they still actually have got a much worse deal than the average patient with physical health as well, which I'll come back to. So much so that we use the term apartheid, you know, to describe their experience, that, you know, it's the same sort of person actually, it's the same patient, and this is still happening today, that a patient can have Rolls-Royce treatment for a physical health problem, let's say a breast cancer, and the same patient will turn up 6 months later in the same hospital and get pretty ordinary sort of access and quality of care in the same hospital and same health system. So, but it was much worse back in the 1970s and with the old institutions and Dickensian sort of conditions and very human rights for the patient. So there were people writing about this. Lang, R.D. Lang, was a very famous philosopher stroke psychiatrist who you know, was a very celebrated intellectual at that time. So I was very impressed with that when I was a medical student, and it was quite exciting, the whole idea of trying to change that. And then I sort of was faced with the reality when I graduated of, was I going to do it? Because the only way to become a psychiatrist was to actually immerse yourself in that very sort of bad system of care. And I sort of put it off for a few years. I did general medicine. I did about 4 years of physician training, went over to the UK and you know, worked there for a couple of years. But then I came back to Australia, and they had set up a new medical school in Newcastle, and where I came from. And it was very modern, it was very progressive. It was based on the McMaster Medical School in Canada. And they had a new professor of psychiatry who had been one of our teachers in Sydney. And she was a very warm, humane sort of person. You know, she projected that like a bit of an earth mother. And she sort of projected that into I suppose, the world, and it gave you the idea that there was a more humane way that this could actually be done, and so they had a new training scheme, and it was possible to sort of move into psychiatry training. And you know, one story I can tell about that experience was I was a medical registrar at the time, and I had people queuing up to try to talk me out of that decision, you know, saying, don't waste your life, don't, you know, you're just throwing your career away on these people, you know. The prejudice amongst doctors was absolutely extreme, you know, and you know, ridicule as well, not just trying to, you know, rescue me from a bad mistake, but actually ridicule, and, you know, just the stigma was in every single health professional pretty much, you know, and you know, the reality of working in those hospitals was pretty grim, you know. You know, patients used to be brought down from virtually the Queensland border on the back of an ambulance, handcuffed, you know, just arrested by the police, mentally ill, floridly psychotic, just chucked in the back of an ambulance, given a shot of something, and, you know, some of them died on the way down, and, you know, just absolutely sort of veterinary sort of medicine, really, you know. And and that contrasted with all of the sort of high-minded stuff that you would be taught in your tutorials as a specialist trainee, and so I suppose you know, the opportunity I had really, which was to I was offered a job in Melbourne one of the academics in Newcastle got appointed to a chair in Melbourne and said, well, do you want to come down to Melbourne and set up a research unit? Because they had the opportunity to actually set up a clinical research unit in Royal Park Hospital, which was one of the hospitals in Melbourne. And so I said, okay, I'll come down there and do that for a couple of years. And luckily what we did, the decision we made was to focus on first episode patients. So people coming into the system for their very first time with acute psychotic episode. And that, as it turned out, because the onset of mental illnesses is the mirror image of physical illnesses, it happens in young people, not in the over 50s or in little kids, but in the adolescents and young adults. Nearly all of them were teenagers or young adults coming into hospital for their first episode. And you could see immediately, first of all, the harm that was being done to those patients by being brought into this Dickensian sort of institution and over-medicated to the hilt, you know, and virtually not provided with any other type of care except, you know, sort of, I suppose, risk management. And even these days, if you go into an acute psychiatric unit in the General Hospital, that's exactly what's happening even now, you know, over-medication and risk management, you know, with very little therapeutic sort of stuff happening. And so it's ironic that, you know, we've shifted things into the mainstream hospital system, but we haven't improved the quality of care, at least at the acute end, very much. But anyway, it was pretty bad. And also the other big thing that which I learned at that time was that the patients were being presented with a hopeless future, you know. So, I mean, much worse than say someone presenting with metastatic cancer. They were basically told that, you know, that their lives were over, you know, that they would never get better. They had schizophrenia. It's impossible to recover from schizophrenia, and they would never work. They'd never be able to finish their studies. That was what psychiatrists used to say to patients on a routine basis with these diagnoses. So, you know, and it was based on a very flawed sort of concept, you know, which came from the 19th century, which was this idea of dementia precox, you know, which was, you know, this was just dementia occurring in a young person, which was completely wrong, you know, and they couldn't find the biological basis for these illnesses, so they grouped them together on the failure to recover principle. So if they didn't get better, they all had the same problem, and very simplistic sort of thinking. And we've still got that. The DSM, which there's been so much controversy about recently, still has this definition of schizophrenia very much in there, you know, very little change since the late 19th century. So, but what you could see with these young people was that, first of all, you had to protect them from the iatrogenic effects of the kind of care that were being offered. That was the first thing. And then try to sort of build a sort of a therapeutic approach. And it wasn't as if, you know, they didn't get better from the psychosis, because they did. The antipsychotics did work, you know, and most of them did actually get, but they were very psychologically and socially damaged as a result. They'd often spent months in hospital. They'd lose their peer group, you know, their families were completely sort of, you know, as you can imagine, frantic, you know. And as time went on, more of them got dependent on drugs and alcohol to self-medicate, and all sorts of secondary problems, forensic problems, and so on. Post-traumatic stress disorder, a lot of them had PTSD as a result of their experiences in hospital, and so it was a nightmare, really. It sounds terrible, doesn't it? But so that's what really motivated me, and I suppose I had the idea, I don't know what Fiona said at the beginning, but I had the idea from the beginning that I wanted to change something, you know. I had that kind of idea, probably from that period as a medical student, that I wanted to change the situation somehow. And luckily I had the opportunity. I was given this fantastic opportunity. You spoke at the end about the privilege of the education, but I felt privileged that I'd been given this sort of opportunity. And psychiatry, far from being a waste, it was such a greenfield site, you know. If I'd gone, I was doing a lot of diabetes before I did that, and I really liked working in diabetes, but I could have spent 30 or 40 years in that area and probably made that much difference, you know. Many other bright people working in the area, you know. But in this area, the potential gains we can make are massive. They still are, you know. It's really such a greenfield sort of area that we can make tremendous progress in. So that's probably one of the exciting things about it. But it was more like I suppose a mission. I felt that I had that feeling, you know, and I still have got that, you know, because so many people's lives are potentially, you know, changeable if we actually do a much better job with these problems. And I suppose then we had Fiona was talking about the importance of the team, you know, having a few like-minded people around you who, because you can't do everything yourself, you know, you might have energy or passion or and some ability, but these are big changes that we are trying to make here. So you need a few like-minded. It doesn't mean it has to be very many. It was probably one or two other people that were thinking the same way, and we managed to get a sort of a program together over the next probably 8 years before they closed these hospitals. So we were getting ready in a way for escaping from the hospital and into the community, and we managed to get money then, probably in the early 90s, which set up something called EPIC, which was a community-based version of what we had been doing in the hospital, and we started to do it in the community. And the first thing was to shorten the delays in treatment, because on average a young person with a psychotic illness had been sick for probably a year or two before they got any effective treatment. And you can imagine, you know, having delusions, hallucinations, sitting in a bedroom, not going to school for a year or two when you're 17, 18, 19 or 20. I mean, it's devastating to your trajectory in life. You know, you will lose your peer group, you'll lose all your sort of sense of momentum and sense of all the developmental tasks are completely sort of, you know, derailed by that. So shortening the delay in treatment was one of the first objectives. So in other words, as soon as someone had developed a psychosis, making it easy for them to be assessed and treatment to be started, and hopefully not in a crisis situation, because quite often they were being brought in after a serious suicide attempt or some aggressive incident because they've been floridly psychotic and become aggressive or some crisis anyway, and the police were often involved. So it was, you know, treatment got off on a very bad footing, and by shortening the delays, by going to them in the home, going to them where they were actually you know, more comfortable and felt safer, you could start things off earlier and in a much better way. So shortening the delay so there's less damage in the first place was one key thing, and then making sure they got a holistic sort of type of treatment with minimal doses of medication, not being over-sedated or over-tranquilized, but actually just very tiny doses of antipsychotic, which was enough to get rid of the hallucinations and delusions, but not enough to sort of sedate or cause all the side effects that those medications had at the time. And I'm talking about the old medications too, the first generation antipsychotics, which had terrible neurological side effects and caused a lot of Parkinsonism and other sorts of side effects. And the new drugs don't do that to anywhere near the same degree, especially in low dose, but they do have other side effects, metabolic side effects, which are, you know, again, still problematic. But anyway, so enough medication but not too much, and then other things, psychological help, social forms of recovery-orientated treatment, and then making sure that they had tenure of care for the first few years after diagnosis, because what traditional services did, and they still do, is just patch people up and then flick them back to the GP, basically, with no real programmatic support. So they might treat them for a few weeks or a few months until they're well enough to be kicked out, basically. And it's not the clinician's fault, it's the under-resourcing of the system. It's just so not to scale, you know. I mean, cancer services are probably more or less to scale in Australia, but mental health services are funded about half the level that they should be funded. It's about 6 or 7% of the health budget. It's about 13% of the health burden, and in young people it's about 60% of the health burden. So there's a huge mismatch in scale, which means the services behave in ways that, you know, are much worse than in the rest of the health system. And this was happening to these young people. So to get that beachhead, to basically be able to provide a sort of a less traumatic entry into the system, into a different space from the chronic patients. So they're not presented with their future. They don't come in as an 18-year-old and see a ward full of 45-year-olds with the most severe disabling illnesses and think, that's where I'm headed. And, you know, I think that was a big contributor to suicide rates in those patients. And so they're streamed in a different way, and they're given a much more positive message, and you work with them until you reach the maximum level of recovery over those first few years. That was the model that we developed, and the government, Victorian government, you know, funded this new program. It was at a time when the mental health system was starting to be dismantled and rebuilt, so it was a great time to do something. You know, I'm coming back to the unconventional sort of things that Fiona was talking about. It was a radical thing, you know. we prospered a lot more when their main system was in disarray than we have ever since, because the red tape and the regulation and the risk management, all those functions have closed in on us and made it much more difficult to innovate and do reform since then. So anyway, so that prototype was developed, and we found, coming back to the idea that you need other leaders and other partners to make change, we found about a dozen people in other countries who had very similar ideas and interests, and we worked with them to set up an international network of people called the International Early Psychosis Association. And that was people like us, who are clinicians but also academics, and were committed to sort of an evidence-based approach, trying to develop new ways of working and then testing them and refining them. And that, I think, that was the value of the research idea, that practical, not this kind of very important but different sort of strategy of trying to discover the causes of schizophrenia. I mean, that's something that people have spent 30, 40 years of their careers doing, and they still haven't made that much progress, to be honest. So we were much more applied. We were trying to find ways to improve the quality of treatment, develop new treatments if we could, and we did develop quite a few psychosocial forms of treatment. And a bit like they have done in cancer, I think, try to improve the delivery of the existing treatments. In other words, make them able to be delivered in a better way, in a more efficient way, and that also had, in cancer, I think, has had benefits in terms of survival and outcomes, and I think that's what we've done too. Haven't been massive new breakthroughs, but actually making sure that the comprehensive package of care is actually optimised and then made available and delivered to people. That's had a big effect, and creating a different culture of care. So anyway, unexpectedly, this sort of movement it became, really, even though it was a very evidence-based movement, has taken off in lots of places. So there are hundreds of these programs now all around the world, and finally Australia is starting to roll out these early psychosis programs. In the last budget last year, they finally committed some money to do that, even though it's completely bogged down in federal-state wrangling. That's the other frustration. I mean, I think Fiona, it sounds like the luxury, if I can say that you can control some of your local environment. Well, in the sort of things that we're trying to do with system reform, it's very difficult to feel in control of a lot of these things sometimes, and also trying to avoid. I totally agree with your idea of trying to not buy into other people's negativity, but when you're dealing with colleagues that are trying to stop you from bringing about these reforms, or bureaucrats that are also protecting the status quo, conflict sort of inevitable, really, sometimes, and that's a sort of a, what's the word, disheartening thing at times, I guess you could say, but you have to fight. I think you were talking about fighting as well, but it is, you have to think about it in that sort of way as a struggle. If you want to actually change some of these things, and you have to believe in yourself too. Sometimes people say, for scientists, these people are just zealots. They're just, they're not scientific because they're not dispassionate enough. But if you don't believe in these things, you're not going to achieve anything. And you still have to be committed to having an open mind that you might be wrong about the details, I suppose. That's what I think. But the actual idea that somehow it's not a good idea to help young people as early as possible when they're really struggling with major, overwhelming experiences, I think you can't question that. You can't question the fundamental beliefs about what you're trying to do if you're trying to lead other people, or if you're trying to achieve change. So even though people will use that against you, some of our colleagues have written papers about the early intervention idea as faith before facts, titles like that in the papers, as though trying to discredit you for the passion, I suppose, and the commitment to what you're trying to do. So, but if you don't have that, you won't ever do anything, I don't think, if you don't have that sort of certain amount of belief, Okay, so I'm not really talking much about leadership, am I? I'm just sort of trying to tell the story a bit, but is that okay, Helen, what I'm doing? Yeah. Yeah, so then I certainly didn't expect it to go that well, I suppose, at first. It went very well in the 1990s because a lot of places it was like an idea whose time has come. You've heard that expression before. Someone's also said there are lots of ideas whose time has come, but they don't actually happen. So the idea has to be produced as well as probably climate change is a bit like that at the moment, isn't it? The idea, but then it's sort of lost its way a bit now in terms of momentum. But an idea whose time has come has to have not just an originator of the idea, but like a stage manager and a producer and a team to make the thing happen. And that did happen actually with the early intervention psychosis, and it did happen in lots of places. You know, but I suppose what we felt fairly early on was there's a much bigger fish to fry than just early intervention for young people with psychotic illnesses like schizophrenia, because if you look at the epidemiology of mental ill health across the lifespan, all the mental disorders that are going to occur happen pretty much in children and young people, so, and especially in adolescents and young adults. You know, you could say that the causes are actually operating in childhood, and you know, even early in childhood, and then, you know, through middle childhood. But in terms of reaching a threshold for treatment or care, only about 25% of cases will present by the age of 12. You know, so then you get another 50% of new cases appearing between puberty and about 25, and then there are some new cases after 25, but you know, but it's only about a quarter. And what you see because many of these illnesses are persistent, or a subset of them are persistent, the prevalence is skewed probably more towards middle adulthood. But if you're looking at the incidence, the new cases, the force of morbidity, it's really happening in teenagers and young adults. And so if you want to have a preventive approach or an early intervention approach, you've got to have a real focus on this stage of life. And so when we looked at the complexion of the health system, it's sort of modelled on general health cares, you know, which is like a paediatric adult model, you know, so, you know, children's hospitals and, you know, teaching hospitals and general practice. And if you go into a GP surgery, generally the sort of patients that you'll see are little kids, you know, or old people, you know, or, well, I'm saying over 50s, I shouldn't say that now, should I? But older people. You know. You don't see many fit, healthy adolescents or young adults in the doctor's waiting room. And if you look at the pattern, as I say, of mental health across, it's the mirror image of that. So, but we didn't have a system of care. We mainstreamed our health system, our mental health system, from the old, you know, Dickensian system into the general health system. It was a great idea. Everyone thought that would fix stigma, but you know, the engineering wasn't right. You know, so there's no strong culturally appropriate system of care for young people. You know, like teenagers up to the mid-20s, which, interesting developmentally, that period of life has changed, you know, in terms of its culture and its developmental sort of complexion over the last sort of 30 or 40 years. So if you were an adolescent back in the, say, 1960s, you grew up a lot faster than you do these days, you know. Although you start earlier these days, puberty sort of, and the adolescent transition starts.
They just mature at a slower rate.
They mature?
They mature at a slower rate, is in emotion.
Yeah, that's right. They start earlier because you have these tweeny type, you know, phenomena. But then they don't need to grow up that until really the late 20s, because you know, with the age of marriage and having first kids having blown out to about 30. There's a longer period of freedom. There's a longer period of economic dependence as well on parents, and so it's got stretched. You know, so that combined with the pattern of morbidity, you know, the onset periods, and the fact that brain development is continuing up till the mid-20s as well, means that you've got to have a different focus, and it's really an adolescent, young adult, or emerging adult sort of focus, and so, you know. If you look at the access to healthcare of young people in that age group, their major health problem, about 50% of the burden of disease, is mental and substance use disorders. They've got the worst access across the whole lifespan to healthcare, you know, in that age group, at least for those problems. And so what we felt then was we had to re-engineer the system so that it could actually provide the right culture of care and access to those young people. Also had to learn a lot more too, because, you know, if you look at the way child psychiatrists are trained, or child adolescents are it's very old-fashioned. You know, they taught about Anna Freud and stuff that was developed in the 1930s, basically, and it's not updated. It's not up to date, and so. But what do we teach them? We have to learn a lot more about what it's like to be a young person in the early 21st century, and the developmental tasks, how they're different, and there is some new research on that, which is, you know, throwing light on that, but it's still very underdeveloped. So that led to I suppose, a very lucky break that we had about 2001, 2002, where the Colonial Foundation came to us. Normally you've got to go and harass philanthropic bodies all the time to get research funding, and but in this case they came to us and they wanted to invest something in the mental health research field. And they'd seen what had happened with the early psychosis work, and they thought, well, you know, they didn't want to just give more money to the Mental Health Research Institute or the Howard Florey or whatever to do more basic research. They wanted something that was more practical and more immediate. And so luckily they came to us, and they have actually then created a new research centre for us in partnership with Melbourne Uni and Melbourne Health, and it allowed us to recruit, you know, a whole series of mid-career academics across the diagnostic spectrum. So we were mainly early psychosis people up to that point, and then we had the chance to recruit a drug and alcohol specialist researcher, a mood disorders researcher, a personality disorders researcher. So we had about probably 5 or 6 of these sort of people that we could actually recruit as senior lecturers or associate professors. And as you know, it's very hard to get money for those sort of positions. But then they were the leaders then of mini teams, which were able to sort of start developing research and clinical care in these new areas. And we stretched our clinical resources. You know, we really had very few clinicians in the non-psychotic area. We had about 15 people covering a catchment area of 1 million people for all the depression and substance abuse and, you know, eating disorders that were in the western suburbs, basically. And there were probably about 40 or 50,000 young people with a mental disorder every year in that population. And we were able to probably treat a few hundred of those. But it was enough to sort of get the beachhead and get the clinical laboratory going in these other areas as well, and to start learning and start creating knowledge. But we realised very quickly that with this volume of morbidity out there, most of it untreated, most not getting any real help at all, that we had to sort of build a new platform, a new sort of infrastructure. So this, not just the research, but the clinical care could be grown and scaled up, and that led us to lobby both sides of federal politics in 2004, before that election, for what became Headspace, basically. I don't know if you've heard of Headspace, but this is a primary care structure, which obviously with these sort of numbers of patients needing care, you've got to have a high volume system. You can't have highly specialised care for all of these kids, because you'd probably, you know, take over the whole of the western suburbs with mental health facilities. So you need platforms of high volume care with more briefer types of interventions and very ready access. And so this was designed and and it was basically thought of as a multidisciplinary one-stop shop. You know, so young people were having to go to about 5 or 6 different agencies to get their different needs met. You know, whether it was employment, education, healthcare, mental health care, drug and alcohol, all the things where they had needs. They were in about 15 different agencies scattered through, so they never really made it. You know, and if they did, the care was very poorly coordinated. So we basically said Headspace has to be a one-stop shop, and we always use the the iPhone analogy. You know, sort of the iPhone where you're carrying around in your pocket something that, say 10 years ago, you needed about 6 or 7 pieces of equipment to do what this thing does. And so that's the idea that we had about Headspace, that it should be like that it should be modern, accessible, you know, engaging, so it actually feels good to go in there. Normally when you go to a community mental health centre, you walk in the door, it's all run down, the chairs are all broken, the staff are hiding behind, you know, a grill, you know, with bars. They're frightened of the patients. The patients are all, you know, very disadvantaged, and it's a very uninviting sort of environment. But so a Headspace cannot be like that. It's got to be youth-friendly. It's got to be engaging. It's got to be fun, welcoming, and, you know, happy to say that most of those Headspaces do have that feel. You know, around Australia, they've got that very. I was just in one in Coffs Harbour yesterday, seeing patients up there, and it's great. It's just a pleasure to go to work in this sort of environment, and the receptionists are friendly, and you know. It's very laid back, and young people are involved in the design and running of the organisation too. So anyway, so that was the next step, and so now what we're trying to do, there will be about 90 of these sites by 2015, hopefully, if the scaling up continues, about 40 at the moment. And what they are now is environments in which more clinical research can actually happen. So let's say 50,000 young people a year are being seen in these sites at the moment, or more, it's probably more. These are cohorts of young people that have never been seen before in clinical settings in this way, and so there's an opportunity to learn about their needs and about the right sorts of mixes of treatment or help that they actually need, and to do a whole series of clinical trials and cohort studies and even studies looking at biomarkers for risk of more serious mental illness developing. So the research opportunities are just amazing through having a new clinical infrastructure, a new clinical laboratory, as long as we can harness it. And I shouldn't be saying this at the moment, but the TCR in mental health for research has just been announced. And I've got to say we're very disappointed, because some of the research proposals were set to take maximum advantage of this new platform, and this is what that TCR scheme was essentially intended for this sort of thing. And unfortunately, it's such a lottery, that we haven't been able to pull it off this time. But nevertheless, I think NHMRC or other research organisations, research funders, this is a huge opportunity for Australia in mental health now, which we can hopefully build on. And it doesn't exist anywhere else in the world. I had the director of NIMH coming out last year, Tom Insel from Washington, and he said that Australia's 10 years ahead in mental health opportunities because of these sorts of reforms and developments. But can we take advantage of it? This is where the other leadership skills that I've had to develop, and my colleagues have developed as well, are really important. Ian Hickey, he's a fantastic partner for us in this advocacy area. He's the director of the Brain and Mind Research Institute in Sydney, and very fearsome, very fearless sort of advocate. That's what we need to do. We need to sort of work in a political and advocacy sort of way in our field anyway. And I think it's probably less necessary in some of the other medical fields, maybe not, but maybe there are more people to do it. It's more effective because you've got about 15 Ian Hickeys in cancer, and we've got one, so we've got a much bigger job on our hands. We've still got stigma to contend with. There's still, even though it's much better than it used to be in the past, thanks to Beyond Blue and I think the Australian community has really responded really well to this, but there's still a way to go. And there's still stigma, I think, in research funding organisations against mental health. There's still the same attitude that I experienced when I was about to start training in psychiatry within the NHMRC towards mental health. I've seen that evidence of that, and I've certainly seen it in other countries as well. So, we've still got a fight on our hands, but we've got a lot more allies and a more sympathetic audience, even within the research community now. It is changing, you can feel it changing, but it's not over. And so, in terms of leadership, I think, just listening to Fiona, I think you do have to have that sort of energy. You have to be able to maintain the energy too, because you do get beaten around the head very severely in these sort of roles. And there's a lot of nasty politics, that we have to contend with, and some of our colleagues, the competition that we have to deal with in research as well. In mental health, it's worse than any other area, I think, in terms of what your academic colleagues will do to you in terms of trying to progress the field. It sounds like sour grapes, but I think it's generally accepted that because it's a more situation of fighting over scraps from the table, people are more desperate and they won't actually play fair in the same way that more secure people will actually be a bit more mature and actually try to help their colleagues a bit more. So that's one of the challenges our field has got, to grow up a bit and to try to support talent where you see it, and especially young talent. I think it's probably easier for older people to support young talent than to support their peers. But those are some of the sort of struggles, and I'm probably not. I'm trying to not sanitise it. I'm trying to say that it is a tough gig if you really want to take on those sort of roles, and you can do it up to in different ways. I mean, you don't have to sacrifice yourself in doing it. But if you're not going to sacrifice yourself and burn yourself out, or not be able to sustain the process of a whole career, you do need mates, you need friends and allies, and you need to believe in what you're doing. And I think I've learned that you have to go to the public. You have to get the public on side, as well. The professional groups are quite self-interested. I'm talking about the clinical sector now. They look after their members more than they look after the patients. you know, whether it's the AMA or the College of Psychiatrists or, you know, the APS, whatever. So the people who are really, that you're trying to do this for are the patients, the public, and they have to know that, and there has to be like a mutual trust there, which will stand you in very good stead, I think, if you're trying to do the sort of things that I've tried to do. But yeah, so, and it's probably also working out, maybe you only work this out at the end of your life or later in your life, but why did you do, what were the reasons that were sort of driving you to do what you were trying to do, to reflect on that a bit as well. You know, is it altruistic? What are the sources of that altruism? What are the motivations? You know, because that will also help you with sustaining it and yeah. So I don't know. I mean, I've probably got right off the topic of leadership, but I'll just try to tell you a bit about my experiences and doing what I've done, and hopefully I can keep doing it for a fair while yet. But because there's a long way to go, but we need more support. We need more friends. We need more other leaders, I think, in the mental health field, and I'd love to see a few more Ian Hickeys surfacing in the younger generation in psychiatry. Okay, let's stop. Thank you.